And yeah, welcome everybody to our webinar today, which is going to be looking at independent advocacy and PPE. Okay, let me get the screen sharing sources. There we go. Right, so couple of setting the scenes today. We really wanted to host something for everyone to come together to just think through the impact of advocates needing to wear protective equipment. And we really recognise that this is totally new for most advocacy services. This and certainly regular use is totally new territory, something that the sector is going to have to get our head around really quickly. So today we wanted to invite Lindsay from People First Independent Advocacy up in Cumbria, who is really leading the way, and Vicky Lowe from Cloverleaf Advocacy, who is doing some fantastic work supporting their advocates with PPE. We wanted to stress that this isn't any kind of legal guidance. We haven't designed the session today to be an instruction in what to do and when, but rather an exploration of what some of the issues could be. And we're going to then hear from Lindsay and Vicky about their experience of supporting their advocacy teams and what some of the issues are that may have popped up through the last six to 8 weeks as they've been dealing with this. Right, so a couple of things. We're going to keep this interactive, as you can imagine, because that's what we do. So we will be doing polls and we will be asking questions. We will encourage you to type in the text box. So we probably won't be using the question and answer box just yet today. We will instead look at the webinar chat. So that's at the bottom of your screen. If you hold your cursor over towards the bottom of your screen, you'll see a black panel pop up and there'll be a speech bubble on the left hand side with the word chat. If you click that, another box will come up and simply type in. There's two options. One is to send the message to all panelists and attendees, or just panelists. I'd encourage you to send it to panelists and attendees, and then we can kind of have a conversation going alongside as you're listening to Lindsay and Vicky. Okay, anybody else want to participate in this poll? We've got about 75 people voted out of 105. A few more seconds and then we'll close out. Overwhelmingly, people are advocates today. So everyone is, of course, welcome. But that's great to see, because we were aiming for, let's share that, can you see that? Okay, so we were specifically targeting advocates, but as I say, everybody is welcome. And if you are coming from other parts of life, please use your experience too. Okay, so one of the questions is around how do you feel about PPE? Is this something that you are confident in? And please do pop your comments and thoughts in that chat box. But yeah, is this something that you are feeling comfortable with or anxious about? Are you feeling relieved that we're now in a place where PPE will probably become quite normal, certainly for the foreseeable future? But what are you what's your emotional state at the minute with PPE? So just pop some comments in that text box as we move along. So some people are mentioning concerned about using it and then how to dispose of it. Thank you for that one. We are definitely going to cover that. Louisa said, I know nothing about it. Okay, that's great. Welcome, because we will be dealing with this. Let's have a look. Haven't used some of it yet. I think it would feel like a barrier to some communication. Yes, it certainly any face covering which covers your mouth and prevents you from smiling at people will. We will be spending a little bit of time looking at ways to keep person-centred. Sorry, there was like a great big Arctic truck outside my house then. Right, focus case. We will look at how do we as advocates keep person-centred. So people have said it can be frightening, distressing. And yes, Nadine, you mentioned that you've got a hearing impairment. We're really thinking about the barriers that PPE and face masks and any kind of visor will impact for people who've got hearing issues and who are deaf. people who lip read, and obviously BSL often relies on seeing the person's face. So yeah, okay, these are great comments, and just reading through them. So people are also reflecting on how much face-to-face they're doing at the minute. Alison, yeah, hi Alison. You mentioned in there about travelling on buses and trains and public transport. We'll mention that a bit later about some of the issues with travelling and PPE. Okay, great. Oh, Natasha, you made a good point about using branded PPE. Yes, particular hospitals using kind of branded face masks or branded aprons, because yeah, you're right, the same way your lanyard would not be from the NHS or the local authority. If you then turn up in PPE that's branded, that would absolutely compromise your independence and that perception of independence. Yeah. This is a good point from Sean about the different rules in different settings. We will be looking at some of the issues in different settings. Okay, forgive me for not reading every single one out. I can confidently say we're going to address most of these things. There's nothing there that makes me think, oh, pants, we've missed something, because that's a good thing. And Lily, yes, we're all for sharing brilliant practice, so please do chuck over your policy and we can share that. That'd be great. And Gail, there's just kind of, before I hand over to Lindsay and Vicky, just that real recognition that we need to be stepping up now our face-to-face visits, increasingly now as we come out of lockdown, and that more and more people will be needing the face-to-face. So PPE is going to be a central part of that process. Okay, right then, shall I hand over to you, Lindsay? Do you want me to? Yeah, over to you.
Thank you. There's a square. Oh, it was on my screen. Sorry, I'm a rookie on these webinars, and the advocacy question box was still up on my screen. I was waiting for you to delete it, Kate. I didn't realise I had to do that myself. Okay, so good afternoon, everybody. I'm Lindsay. I work at People First, and we're primarily based in Cumbria, and we have, from the beginning of the COVID-19, we haven't stopped face-to-face visits. We've been stopped from doing some face-to-face work from other settings like care homes and hospitals, but actually we have continued to do face-to-face. It was limited for a little while, but it's increasing now. So we're here to talk to you a little bit about our experiences. So what is PPE? Well, it's personal protective equipment. It is something that people use to protect themselves from dangers at work. It could be face masks, it could be goggles, it could be working in a factory, your metal toe cap boots, helmets, you name it. Anything could be classed as PPE, but this is really quite new for the advocacy sector, I think. Working as an advocate for many years, when I was thinking about my experiences of PPE, it's always been when I've turned up at a hospital ward to see somebody. I've been passed an apron and passed some gloves and a mask and said, oh, there's sickness and diarrhea on the ward, you need to wear these. And that's been absolutely fine up until now. And I think now we're recognising there's a real difference, because it's not just about sickness and diarrhea. Obviously, it's about us catching and transmitting COVID-19 and coronavirus. So very quickly we had to think as an organisation, what do we need to do and put in place. So could you flick on? Very quickly we went to the Health and Safety Executive website, and we learned about whose responsibility is it for providing PPE. And it is basically, it's your employer's responsibility for providing PPE. So if you need PPE to undertake your job as an advocate, then it is your employer's responsibility to provide that for you. And that's defined by the Personal Protective Equipment at Work Regulations, 1992. And it very, very clearly states that. And that's a big step for employers. So I think it's really important that employers and employees work together to look at what kind of PPE they need for the different types of advocacy that they're providing. Vicky, do you have anything you wanted to add to this bit?
No, I think you've been really clear on that. Hi everybody. Vicky from Cloverleaf. Very, very clear. It is the employer's responsibility, and they should have identified that responsibility through a very, very clear risk assessment, an organisational risk assessment for COVID-19. Varies in terms of the settings that we're going into. Cloverleaf, we provide IMHA, IMCA, all the advocacy disciplines, and in people's homes as well. So there is a need to do risk assessments for those as well, an organisational risk assessment. So yeah, it is through that risk assessment that will be identified that PPE is needed, and therefore it is the employer's responsibility.
Yeah. I've just noticed that there's a question popped up about self-employed advocates. I think that would be slightly different, and you probably have to look at your contracting arrangements that you've got, because I'm not a legal expert. So I think definitely self-employed, you would need to look at your contracts. But definitely, if you're employed by an organisation, it is your employer's responsibility, and that's really clear. So the next slide, please. Okay. Is it coming along?
Yep, I think we're on it there, Lindsay.
Okay, perfect. Am I expected to pay for PPE? So this is a really important point, I think, because I think it's probably covered by the previous bit that we were talking about, is it's your employer's responsibility. So actually you can't be charged for PPE, but there will be some things that you might want to provide yourself. So an example is when you are wearing PPE and you're wearing a face mask, one of the pieces of advice given is to tie your hair back. So to tie your hair back, if you've got long hair, you obviously need a hair bubble. Now, you could actually argue, well, it's PPE and my employer needs to pay for that and provide me with that. But, you know, I don't think people would go into that level. So there is some things that you might use to protect yourself that you would provide yourself. And I think a hair bubble might fall into that. But obviously that's up to individual organisations if they want to provide hair bubbles. But it's absolutely, you shouldn't be expected to pay for PPE yourself. Okay. Thank you, Kate. Okay, so this is a really interesting bit. So what PPE is recommended in different settings, and there is some guidance. The link is below. Could you just go back 1 second, Kate? Sorry. There is some guidance on the government website, and it is updated regularly. So when we were developing these slides, I think it was the 5th of May it was updated, and then when we came again it was the 20th of May. So it is updated regularly, and they're quite small changes, but it's really important to keep it up to date. So keep looking at that link, because the link doesn't change, but the guidance does. Sorry, Kate, we can move on now. So on that link, there is some really helpful YouTube videos of how to put on PPE and take off PPE, and that process is called donning and doffing, which we're going to cover a little bit later. But in that in the guidance, there's a number of different tables which recommend different types of PPE for different settings. And Vicky and I, we were both with our organisations. Table 2 is the most relevant for ourselves. And this very helpfully, obviously, we're not expecting you to read that. I had to go and print an A3 sheet just so I could read it. But it very, very clearly sets out what kind of PPE you might want to use when, and it talks about the mask, the type of mask. It talks about the frequency you would need to change your mask, whether it should be disposable or not, and it also talks about aprons, gloves as well. So Vicky, do you want to tell us what type of PPE do you provide your advocates currently?
Okay, so through risk assessment and looking at this table, the table suggests that yes, if we were going into care home settings, communal areas, that surgical face masks, FFP2 face masks are needed. We are providing gloves as well, although it states that this is not needed. hand sanitizer, disposable equipment for the doffing, the taking off, and how you're going to dispose of that. In addition to this, we've done a guidance procedure and began consultation with staff on that, in terms of getting all their sort of queries and questions, because I think, you know, one of the questions was, well, can we not dispose of it in the care home? My answer to that is that's a bit concerning sometimes, because actually, where will the clinical waste be? Then do you have to search for a member of staff then to find that, and then you're again roaming around that home, which I don't think they'll want us to do. So like Lindsay, we've done that as from the beginning of the visit, so before leaving the house where that preparation is needed, to then disposing of that when you've left the care home or the home or the setting, etc. So yeah, the disposable bags as well. And wipes we are looking at getting as well, because just in terms of wiping steering wheels down, gear sticks, handbrakes, etc., when you get back into your car, I suppose it's about being mindful about keeping on top of that supply, making sure that you've got a good relationship with your supplier is another one, and making sure that you have back orders, because also they are ordering that in. And one thing I would say, since government sort of briefings have said that private companies, people who are furloughed, might be going back to work, then the increase for that PPE has increased significantly. So I made sure that we had a back order for that before everybody else started ordering that as well. So it's making sure that you're planning ahead, and making sure that staff are telling you not just when they've run out the night before, but giving you a good chance to get this order in. And essentially, if for whatever reason, if we can't get that, then we can't make visits. It's as simple as that.
So thank you, Vicky. So the PPE we provide, so when we, still on the table, Kate, so when we started thinking, crikey, we need to provide our advocates with lots of PPE, it was quite early on in the pandemic, so the risks were obviously very high and it was very unknown. So we went and produced a procedure which, because the guidance was so complex and it was changing regularly, we went to the extreme end of the scale. So we provided, and I've written down the list, I've got it behind me, but we provided disposable and washable face masks. We provided disposable aprons, gloves. We provided antibacterial gel, antibacterial spray and disposable cloths. We provided head visors and carrier bags. So we didn't provide the hair bubbles, but and what we said to advocates, because actually there was some real apprehension about advocates going into settings and visiting people, because obviously they were worried about catching coronavirus, but they were also worried about transmitting it. And so we needed to try and support our advocates feel really confident and comfortable. And we had a training program, but we also decided to go quite extreme. So we provided masks and visas, and we expected everybody, no matter what setting they were going into, we said, just put it all on, get used to it, get used to donning and doffing it, putting it on and off. And then as the weeks have gone on, we are reviewing that process. So we're not having the visor in every setting now. So we would use this visor if we were in a hospital setting where there may be increased risk of fluid contamination, but we would use a mask all the time, and we would use an apron and gloves, but the visor changes a little bit. And the antibacterial spray and the antibacterial gloves, the antibacterial spray and the disposable cloths was about making sure we could clean that visor really well, because obviously visors aren't always disposable. So I'm going to just show you the visor, because there's lots of different types of visors out there. And we were actually provided our visors by a local organisation that had it was a private company that had just changed what it was doing in the face of COVID-19. And what's really good about these visors is that the elastic at the back is removable, so you can anti-back your actual visor, but actually you can pop that in the washing machine as well when you're taking your clothes off and washing your clothes. You can wash the elastic as well. So, you know, if you are looking for visors and things, just, you know, be mindful of making sure it can all be washed and cleaned really well. Okay, I might be going off on a little whim there, but it's okay. I'm an advocate. I talk a lot. So, okay, shall we move on to the next slide, Kate? Is that okay? Okay, so when does PPE need to be replaced? Again, there is guidance around what is able to be used for a single session, or what is able to be used for a specific period of time. And Vicky and I, we were talking about this quite a lot, weren't we? Yeah. About, well, what would it be? So we have masks. This is one of the masks. And we wouldn't change the mask between every visit with every person in the future. But now our organisation is only doing 1 visit per day per advocate. So as we move through this presentation, you're going to hear about our process. We've got a little bit of a video of an advocate, but our process starts with a shower at an advocate's own home, and we only see 1 person, and then we go home and finish our doffing procedure. So we only use 1 mask at the minute per session, but moving forward, if we were seeing more than 1 person at a care home, we would change our gloves, apron between every visit, but we wouldn't necessarily change our mask or our visor. They would be for a full session. So if you were moving to different settings, then you would absolutely need to change your mask and your visor. So the government guidance very much talks about sessions and settings and delivering. So a lot of it is about delivering care, but there is some guidance as well about working in people's homes. You know, if you're an electrician or a builder, and that has some helpful guidance too. Vicky, do you have anything you want to add about the sessions? You had a really interesting point about care homes and visits.
Yeah, I think my optimistic outlook is that if we're going to care homes and maybe our PRs have 3 people to see in there and they're mobile, and hopefully the care home would have a room that's available and people can come to that room, because obviously we don't want to be moving around that home a lot. Now, obviously we could social distance in that room and they clean that room down, and this will all be in consultation with the manager, booked appointments, etc. And then in that would, to me, class as 1 session for the mask and for the gloves. In terms of visits, what we wouldn't be doing is then going to another care home, because our guidance is that people need to shower before they leave and shower when they get home. So essentially it's 1 setting per day, pretty much like Lindsay saying, one visit per day. So if we've got multiple care homes to go to, we would have to do those on different days currently. We're reviewing that guidance fortnightly. And obviously it would depend. There is a robust risk assessment in place that asks if there's been any symptoms in the home, if there's been any diagnosis in the home, sadly if there's been any deaths in the home in the last 14 days, etc. We have to go through all that on the day with the home, and if there's any indication at all that there is COVID in there, then we wouldn't go.
So there's some questions coming through about, would we use less PPE for a meeting outside in a garden, Vicky?
I wouldn't. No, I've still said that, you know, we would still use the face masks. Currently, it would be reviewed, and the gloves. If you think about the gloves, hopefully I've risk assessed an appointment this week in terms of, right, actually how are you going to get into the garden? So that's through the back route. It's not going through the main care home reception door. So in actual fact, who's going to be touching that door handle? How are you going to get in? Because really the less you touch anything, so we wouldn't want to be touching anything, but also it's about us taking it in, not just about us bringing it out. So we wouldn't want to take that in, so we would still wear the gloves and we would still wear the face mask. Just to note as well, if any advocates have any symptoms at all, if they're in the high risk, sorry, my dog is here, sorry about that. If employees are in the high risk category or the shielding category, then they wouldn't be doing visits either at the moment. Yeah, that's just to add on to that.
Yeah, we've had some individual conversations with staff. I think I see some questions coming through about getting PPE from hospital settings and care home settings. and you know, every organisation will do their own thing. They'll take the guidance and they'll use it for the benefit of their employees. My concern about accessing it from hospitals and care homes is that they have enough pressure to access their own PPE at the minute. They're under a lot of pressure, and based on our interpretation of the guidance, we feel we need to start that process a lot sooner. You know, it's our PPE from in the advocate's own home that they're taking out to the care homes, and I would just err on the side of caution about that.
I think, Lindsay, as well, for us, it's our responsibility. As an organisation, we see it as our responsibility to supply that PPE, because you could get to a care home and again, is there a member of staff there to provide it as soon as you're at the door, etc. And it's just ambiguous, I think, that for us as an organisation. So we're definitely providing that.
Yeah. Okay. And I think, you know, there are obviously some benefits from using care home and hospitals PPEs, and that's got to be financed. You know, like I've been involved in other conversations around PPE with other organisations, and I've heard people say, "Oh, we've not included that in our, you know, we've never thought about PPE when we've been doing our commissioning and different things." But I suppose we're saving on travel a little bit at the minute, and it might even itself out. But yeah, it is. You know, it's individual conversations, I suppose, with commissioners as well. We've our commissioners have been really supportive. They've told us that if we cannot get our own PPE, then in urgent cases they will help us to source some, because a lot of local authorities have their own emergency supplies for care homes and hospitals if they're struggling. Okay, I think we're ready to move on, Kate, if that's okay. If we miss any questions, should we just do a catch-all at the end as well?
Yeah, I'm currently just writing some down and trying to respond.
Yeah, that's okay. I'm just aware that I'm trying to read and...
Oh yeah, no, don't worry. Let me.
Yeah.
I'm writing them down.
Okay.
Thanks, Lindsay.
Yeah.
One of the things I thought was interesting in our planning session was around public transport and who's responsible for providing PPE. Could you just share your views on?
Yeah.
Yeah.
So I think it depends what that travel's for. So are you travelling to and from work and using public transport? And if you're travelling to and from work, then I think it's the individual employee's responsibility to provide their own PPE. If you're travelling on behalf of work, then I would say it's your employer's responsibility. You might want to use that as part of your risk assessment, as in how are advocates travelling to places, because there are opportunities for more exposure on public transport than there might be in your own vehicle. Vicky, do you want to add to that?
Yeah, I certainly can do. I agree with Lindsay in terms of the responsibility on the commute and then between appointments. What we've done as an organisation, we have few members of our teams that don't drive, and at the moment we've said that no visits, because again it's as much about taking the virus into the settings and being responsible to our clients in the settings as well as it is to Cloverleaf employees as well. And I just think using public transport heightens a risk that for me was just one too far at the moment. So it's a case of actually anybody who uses public transport will be doing the virtual calls and not the visits.
Brilliant, thank you. So I believe we've got a little video now. Is that right?
Fingers crossed.
You might want to turn your volume up on this, yeah?
Hi guys, my name is Lindsay and I'm here first. Soon we'll be talking about PPE, specifically doffing and donning. We were actually going to film this outside the back of the car, but it is horrendously today. So as a cameraman, we said full PPE and still in this video. Thank you. Okay, so this, as you can see, is all my actual PPE. But first, I just want to go through the prep. Few top tips from me, obviously. New facial hair tied back, red short sleeves, control over it. The reason for short sleeves above the elbow is so that you don't have long belly sleeves, because then cross contamination could step. Okay, make sure you've got clean hands, clean hair, and you're in nice, clean, comfortable clothes to go and do the visit. Okay, brilliant. Let me tell you what this is all about. Okay, so.
Okay, I'm going to make the executive decision to stop it because too many people can't hear it.
Okay. Do you want to turn the sound off and we can talk through her doing that?
Great idea, Lindsay. Do you want to do that?
Yeah, I can do. So,
have you done this before?
Have I done what before? Technical problems all the time. I have loads of technical difficulties. It's on my CV. So what Lindsay's doing is she's laying out all the PPE and she's using a disposable mask. And what she's doing at this point is she's showing you how to put it on and explaining that there are some pleats in the mask and which way those pleats need to be used so that you know which way they go. She's talking about the stitching, and the stitching is let me just see if I can find my disposable mask. What she's explaining is the stitching goes on the inside, so depending on the type of mask. What she's showing here is along the top of the mask there is a little metal bit, and the metal bit is to once you've put the mask on is to squeeze around your nose. And the reason we squeeze it round our nose is to stop the extra space for droplets to possibly leave behind the mask. Because the main reason for using the mask is actually to protect other people from yourself. What Lindsay's showing there is that some people use washable masks, which are homemade or made by different organisations. And what she's saying is for donning and doffing, for taking it on and off, it's easier to make sure you've pre-tied the mask before you put it on. And the reason you would pre-tie the mask is so that you're not having to, when you're taking it back off, you're not having to worry about undoing it too much. It's easier to just flip it off. So what Lindsay's showing you there is it's important to make sure it is good fitting and it is comfortable, because obviously you need to be able to breathe under the mask. So this is the stages that Lindsay's using. She's putting on her gloves first. Okay. And then she's putting on her apron. And these are disposable aprons, and they come in different packs. But we like the rolls of apron. They're really thin. They don't have to be thick, because actually, when it comes to taking them off, you can just rip them off without untying them. So it doesn't matter if they're quite thin. So there you go. She's got her apron on. She's got her hair tied back. She's got her short sleeves. That was so that when she washes her hands, she can wash her hands all the way up, and there's a lower risk of transmitting COVID-19. She's popping on a face mask, and there she is, ready to go. So now she's going to take it off. Sorry, this is probably a little bit painful, me talking you through what she's doing. So there you are. She's ripped the apron off, and she's tying it up squeezing it into the smallest possible ball, and then she's using her finger to unloop the mask. With what she's saying there is she's try not to touch your face. So you're not wanting to touch your face. I think she's going to show you again. There you go. There's a little bit there. Pop it in your finger and pull it off. And she doesn't touch her face at all. And then she uses the mask and the apron and squeezes it all together as well. What she's going to do next is she's going to take one glove off. Okay. She'll take the glove off and she'll put that in the carrier bag. Now, why we provide carrier bags is obviously for the disposal of the PPE. In an acute setting, there will be yellow bins. It's a sterile environment. They will have proper places to dispose PPE. But actually, in care homes and, as Vicky mentioned earlier, people's own homes, they won't have a sterile bin. So we take our rubbish home with us. Even for hospital settings, we take our things home. So what Lindsay's doing there is she's showing that she's kept her car key in her back pocket, and that was so it was easy access. What we might do is we might try and improve the sound for this and share it at a later date as well, Kate. Is that okay?
Yeah.
So what Lindsay's explaining there is she's got one clean hand and she's got one dirty hand, and the other carrier bag, her second carrier bag, is used to remove the dirty glove, and then that gets screwed up as well into a ball and put in the bag, and the bag gets tied and it gets disposed of. Thank you, Lily, that's very kind of you, saying this is really good. Okay, so there we go, and then she uses anti-bac gel, and as you can see on her side as well, she's got some spray and some disposable wipes. Now that would be if she was using the visor, which at the minute, obviously we're reviewing our policy and we're not using it in all our settings. So that is how we don and doff the PPE. Yes, you can absolutely get a recording of the presentation and the video. We can try and work out the sound a little bit better. But I think it's really important just to highlight that the donning and doffing will be different in a hospital environment, because they will have, it is a sterile environment, and they will have their own procedures. But it's really important to, when you're planning a visit, to ring ahead to the setting that you're going to be visiting. So you ring in to speak to the person or people with the person to find out, are they experiencing any COVID-19 symptoms or anybody they live with. But you're also looking at, actually, do you have any specific PPE procedures? But we still, even in a hospital, we've been in hospitals around safeguarding, we've been in hospital, on hospital wards, and we've still followed this procedure. So we've done the donning before we've gone into the hospital and when we've come out. Okay, so the next slide, this is a bit of an open discussion really. I know there were lots of questions around communication and aiding communication, and anxieties about face masks, reducing the ability to engage with people. They can't see you smiling. You know, it could be a barrier, and we just stole, well, I stole this photo off the internet, but you know, there are some people who are going out of their way to make masks which do have clear spaces. And Kate, we had a discussion before, didn't we, about there's some real pros and cons of there's some real pros and cons about this type of face mask. For one, it is homemade, and you might not be able to guarantee that it is completely safe to use. You know, the stitching around the side you would need to be confident. It would need a metal bit around the nose so you can press it in to protect yourself and others. And also it might steam up, so when you're talking, the clear bit might actually get condensation from your warm breath. But Kate, you had an interesting tip about that.
Yes, so I'm just making a note actually. Right, so I've just put the group on the webinar chat. So it's a lady in, I think, Salisbury, who is design, and she's an engineer, and she's thought around how to make, her organisation's called Face Friendly Masks. So if you Google her, she'll come up. I just can't remember the lady's name, forgive me. But she's done a clear plastic exactly like this, and what she's done is, to stop the condensation, she rubs a bar of soap over the mask, the plastic bit. Obviously it's all cloudy, and then you just get a cloth and rub it in, and that kind of takes away the smear on the plastic, but prevents the condensation from appearing. Now, I don't know whether these are up to standards. I'm aware that, you know, the stitching around the plastic may compromise the what's the word I'm looking for? How safe they are. There's a word, isn't there? Anyway, so we don't want to recommend anything, but it's definitely worth looking at. And I think that the organisation of a face-friendly masks, they're looking into that issue. So yeah, but yeah, I think just to go back to what Lindsay was saying, we are really aware of how important advocacy is to be visibly seen as independent, being person-centred, and the idea of covering up our face, particularly for so many people who we work with who are non-verbal, and you should go in without being able to smile or to just use some very simple non-verbal gestures is going to be hugely problematic. So yeah, we wanted to ask if people had any ideas or thoughts of how to overcome this, because it's something we're going to have to fix. We're going to have to deal with this. It's not going to go away. And I think if somebody with dementia who might find that very frightening, somebody with learning or hearing impairment, I mean, the barriers are obvious. Yeah, so I don't know.
To date, we've had positive experiences with PPE. Just while people are typing their thoughts, we've had some really positive experiences. We've had a gentleman recognise an advocate's car, so they were near the car. They've had cups of coffee together. We've had different music playing for people so that they could recognise that it was their advocate, and so far people have engaged really well, and that made me start thinking about whether people are getting used to PPE. If you're living in a residential care home, you will be used to seeing people in PPE, and I'm wondering whether it's starting to be a bit more normal for people. I don't know. Vicky, do you have any thoughts?
Yeah, I think when I spoke to our supplier, we had the same conversation, and we've consulted with quite a few members of staff regarding it, and this was the main issue. I think for me though, and I suppose not with my advocate head on, but with my health and safety head on, is what we supply needs to be effective, and if it's not effective, then there's no point in supplying it. And if it increases the risk of transmission, both from you or to you, then I think it's ineffective. I think somebody's just put a question on that this lady is getting this tested, and that would be good. But for me, I've gone down just the clear FFP2 surgical mask route.
This one.
And I do, yeah, so that's 95% of particles will be stopped out or in terms of that mask. And I do recognise that it is a communication issue, and somebody has put on one of the comments as well about a picture of yourself, a smiling picture, which is something else we've discussed this morning, just in terms of sort of trying to keep it real for people, because it's going to be difficult in terms of communication, and that's something again that we're looking at, because I think it's a good idea, but again it's about disposing of that from when you leave, and you can't have the same picture on, because essentially I've looked, and I've looked at on the internet this morning, and it can stay on paper for 4 days. So there is that issue as well. I don't know how true that is. It was on the internet. It said it's been published in the Lancet in terms of how long the virus can stay on paper. So again, that would have to be built into guidance in terms of donning and doffing if we're having pictures, and that's something that I'm looking into a bit further.
Yeah, I think there are some ideas where it could be if you wanted to reuse it, you could possibly laminate it, and then it could be sterilised. Or I've seen some hospital staff using stickers, like large stickers, popping it on the scrubs, and then when their session has ended, then they just dispose of it, like when they're doffing their PPE. So I suppose there is also, we talked about telephones. So something else that we've talked about is like electronic devices. I know someone else has just put taking notes.
Yeah.
Thought about, obviously advocates will need to take, if they're driven there, they're going to have to take the car key in with them. So having it in a back pocket is really easily accessible. You don't have to funnel around everywhere looking for it, and we also decided that advocates needed to take the phone as well, and that was around lone working. So not all of our visits have been in care homes and hospitals. We have had a number of safeguarding referrals where people have been in their own homes and needed some support in their own homes from us, and obviously that's a little bit more of an unknown, you know, with regards to people experiencing PPE, and also with regards to risk. So we have said that advocates need to take their mobile phones with them. If notes were needed to be taken, I suppose you could use an electronic device. We haven't taken pens and paper with us into our visits as such. Currently, we haven't done that. It's something to consider, and you know, I'm going to write a little note to speak to the advocates to see whether they've needed to. This is such an opportunity to go paperless, isn't it?
It came up for us, Lindsay, on a consultation this morning, the notes, because I'd thought about this, and that's why we looked into how long it stays on surfaces. And I'll be honest, I don't have a plan in terms of paper and pens and notes going in, but I know it's crucial to advocates, especially RPRs, and if cases are in COP, that we might need to say things verbatim. And my memory at the minute, and I'm sure everybody else's, it's like trying to retain information seems quite difficult at the moment because there's so much information about. So it is a key thing for advocates, and it's something that we're looking at. We've looked at small pencils like IKEA pencils, but again, there's the sustainability in terms of the environment as well if we got rid of a pencil. So there's lots of things to think about, and that's come up for us today. So again, it's something we are thinking about, but I don't have an answer in terms of an organisation where we're at on that yet either. It's a tricky one.
Maybe we need a hashtag for Twitter. So if anybody in the webinar today does have some really exciting solutions to these issues around note taking, you know, let us know. You know, it'd be great to hear other people's experiences and get advice from other people as well about what works for them. Definitely, I think phones can be cleaned as well. You know, I answer back my phone regularly, and I'm sure you know you all do. So I suppose phones do have the ability to take notes, so you could take a note on a phone, but I know there's some places where you can't take phones if you were going into prison, for an example. I know not many advocates are actually getting access to prisons at the minute, but when you do, you can't take your phone anyway. So you do tend to take a notepad and pen. It'd be interesting to probably risk assess that now.
Lindsay, sorry to just just coming in on that somebody's just said about the data protection and phones, etc. That's something else we've thought about. The practical difficulty about using devices is, and I learned this the other day when I was trying to do a video myself and testing it out. My phone was ringing, and with the nitrile gloves on, you can't swipe, so you can't take notes very easily. It would have to be some kind of laptop with a keyboard, which again then presents another risk. So it does need some thinking about in terms of that, because with the gloves on, it's incredibly difficult, if not possible at all. And then in terms of recording, obviously then there's consent got to be gained from everybody, and then you've got capacity issues maybe around consent to record, and then there's the data protection issues around that. So there is quite a lot to think about. Notepads and pencils are definitely going to be a watch this space, and like you say, a hashtag might be needed for everybody's consolidation on thoughts on that. The photo thing, thank you for Janine. Sorry, Lindsay, she's just put that. We're thinking about that, Janine, as well, about taking the notes on paper and then taking a photograph and then disposing. But again, it's that disposal of that paper. So it is quite a process in terms of thinking about that, definitely. Unless
we all just become really super advocates and memorise everything and have photographic memories, you know, that would be the easy solution, wouldn't it, Vicky? You know?
Yeah, it's certainly not going to work for me, that one, I can tell you.
No, I think while we're doing it, like for example, while we're doing one visit, one face-to-face visit a day for our advocates, I think, you know, it is easier not to take a pad and pen with us, but I think it will become more complicated. So it's definitely a journey that we're on, isn't it?
Definitely, and can I chip in that there's probably, you know, the standard advocacy when you go to visit somebody would be that you're there for an hour or so, maybe 20 minutes with the person, a couple of, 10, 15 minutes with the staff, another 20 minutes sitting in the office going through notes. And I think that will change, won't it? Because you don't want to be any longer at the place than you need to be. So the conversations with the staff might take place by phone. The accessing the records might be electronically rather than in person. So the amount of detail you need to remember might shift a little bit. It's not going to be the whole session. It might only need to be 10-15 minutes that you could realistically write up later. So yeah, but listening to the comments and both yourselves, it's clear to me that this is something that we're going to have to learn as we go on. And as we come out of lockdown, the rules are going to be changing week to week, aren't they? And going into a care home with COVID is going to be a completely different risk than going into a care home that hasn't got COVID and hasn't had COVID for 2 weeks. It's going to be different, isn't it? And we really need to be confident in making these decisions day by day about what the risks are likely to be.
And I think when we are talking about making decisions, Kate, I think it's really important to just note that decisions shouldn't be taken in isolation by individual advocates.
Lovely point.
You know, advocates really need to get support from, you know, the line management and their organisation, because at the end of the day, it is the employer's responsibility to ensure that their employees are safe. And you know, I don't think it would be okay. Again, I'm not a legal advice, but I personally don't think it would be okay if advocates have to make those decisions themselves without that support. And if, I suppose, if they're self-employed, then, you know, who commissions them to do that piece of work? I think, you know, there needs to be some conversations that take place about, you know, prioritising visits, when it's safe to visit, what processes need to be put in place in order to make it safe. Actually, is it just not doable? You know, I think that's a big decision and a lot of responsibility to be placed on individual advocates.
It is, and just coming in there, Lindsay, part of our risk assessment is that essentially everything will be trying to be done remotely first, and if a visit is absolutely necessary, then a risk assessment will have to be carried out with the service manager. Yeah. And that will be logged in terms of on our case notes, and we've got a specific risk assessment tab for that on our case system. And again, thinking about that, and that's for every case, and I think that will be going forward for some time, to be honest. Yeah. Just to note as well, if we do identify that there is COVID in a care home or in a household, or again, I would be saying we wouldn't go.
Yeah, the risk's too high.
Yeah.
Okay. Is there any other points, Vicky, that we've got? Or has any interesting comments popped up about keeping person-centred? I know there were some questions before the webinar about communication with deaf people who use British Sign Language, and we and the challenges that might bring with regards to face masks. There were, and again, I think it's about individual conversations about whether looking at how that might be possible and whether it would need to be remote, with utilising technology like Zoom or Microsoft Teams, or whether you could I'm not an expert in BSL, but I'm sure there's a sound off sign where you use sign only, and I suppose utilising staff who know the person well, but I think that's a whole other webinar around relying on on support workers for advocacy and independence and all that sort of thing. It's a real challenge. Were there any other questions that we've not covered today, Kate?
A couple, but we'll do them at the end. I think one of the things is this idea of, if there's COVID on the ward or the care home, is that a definitive no, we're not visiting? And I suppose I'd chip in. It's about constantly looking at the particular circumstances at that particular time. Yeah. You know, so if let me give you an example of somebody who's detained under the Mental Health Act and has been in segregation for a year, and they haven't had COVID, then the risk of visiting that person, I think, is arguably lower than visiting somebody on a main ward where somebody else has had COVID, even though they haven't. And I'm not saying that you shouldn't visit that person either. It's about looking at, and I suppose we talked in previous webinars about the default position before COVID would be to visit the person unless there was a reason not to. Now in COVID and the coronavirus pandemic, it's flipped. What we're saying now is don't visit the person unless you have a reason to. And I think that starting point is quite significant. So if you can confidently undertake your advocacy remotely, then you should. And that's where I think, Lindsay, your reflective point around, if you're supporting somebody who's deaf or uses BSL or lip reading, then a remote visit on a Zoom call might be the most effective way to do your advocacy. So that's kind of the starting position, isn't it? So there are no blanket policies. Risk assess it on a day-to-day, week-to-week,
individual basis. Yeah. Definitely. I think alongside that, I think it feels really uncomfortable, doesn't it, that we're in that position, that the default is no face-to-face visits unless it doesn't feel great as advocates.
No.
We all understand that. I'm sure everybody can relate to that. It is a complete different way of working, and we're on a journey again through transition as restrictions ease a little bit. I think we're going to be revisiting this topic for quite a while things keep changing.
And somebody's mentioned in the chat whether I'm just looking for the comment now, whether I can't find it, so forgive me for paraphrasing if I'm incorrect, but are we accepting care homes kind of feedback about how things are? And I think as advocates, whether we call it healthy cynicism or professional curiosity or just being downright pushy, that there's something in the current crisis where we don't want to add to the burden on the NHS or the burden on care homes, who are on the whole going to be doing their damn best to care for people. But we are there, aren't we, as an independent voice with people, to make sure that backstop of human rights. So it's deeply uncomfortable not being able to go in. And I think it was Jonathan that was suggesting, that, I don't know what you were suggesting, but you were asking the question, weren't you, Jonathan, about are we taking that at face value? I think was the phrase. But we've got to figure this out. So I think the more we can hear from one another, the more we can shape it.
Yeah, I did, just before we kind of finalise, because I know we're pressed for time, I did notice some practical questions about PPE and donning and doffing, and whether people put on the PPE at their own home. Our procedure is that we prepare our PPE at home, but we put it on when we are about to go in the property. So we do it outside, in the street, at our car, and the same as doffing. We take it off before we get back in the car. The reason the video was recorded inside was because it was incredibly windy, and if you thought that sound was bad today, it was even worse when it was done outside. We don and doff after getting out of the car and then going into the setting, and then when we come out of the setting, we take it off.
And we do the same, Lindsay. Yeah. So
yeah, do you do the same?
Well, we're doing the same, isn't it?
Yeah, that is brilliant. Thank you very much, everybody.
So yeah, we're coming to the end. Did you mention, Lindsay, that looking at the very final bullet point on this last slide, about expectations for how many people we will realistically be visiting?
Yeah, I think I covered that, because at the minute we're doing one-to-one, but actually what we didn't cover was, well pointed out, Kate, was actually the preparation and the planning and the time it takes to plan visits. So it's not just a case of what time of day is a person most able to engage with an advocate, and planning your visit around the person. Obviously that's still there, but then there's also that actually I've got to think about the time it takes for me to get myself showered, get my PPE ready, travel to the appointment, put my PPE on, go into my appointment. It's a lot of all the risk assessing, and contacting the setting beforehand to check about COVID-19. It does take a lot of time, but it's definitely the right thing to do. The planning and preparation is key for a successful visit. Vicky, would you agree?
Definitely, it needs to be taken into account. Just one more tip, I suppose, is if there's a social worker or mental health worker involved, speak to them about what they've done in terms of risk assessment as well, and feed in and work collaboratively that way on that, because that's really important. Because it might be that they visited before, and whilst you'll still need to individually risk assess on that day, they can give you a lot of that information because they may have seen the client patient beforehand. So definitely work together on that. The other thing is just that individual approach, I would say, to risk assessment. Whilst we've got the generic ones that we have as organisation ones, it's remembering that each person is individual and each situation is individual. So make sure that you're discussing those with your line managers when you are risk assessing. It's that person-centred response, isn't it, and a holistic approach to it, definitely.
Yeah. Okay, any final questions? We've had one from Sharon about how do you go about a risk assessment if you don't know if someone has COVID-19? And that recognises that not all sessions are testing people. And even if they are testing, you not having any symptoms doesn't mean that you're negative. So how do you kind of incorporate that risk? If somebody's positive, it's obvious, but if they're not positive, not symptomatic, that doesn't mean that it's risk-free. So are you taking a very cautious approach, which I think from what you've shared today you are?
Yeah.
And any thoughts on that?
Yeah, I think for me it's questions. There are never too many questions in terms of risk assessment. Look at the controls that are already in place. Look if you need more, mitigate those. If you're going into a care home, it is about, have you had any symptoms, like I said earlier, any diagnosis, etc. I know there's been some, sorry, I haven't got my glasses on, so I can't quite see the questions, but I know there's been some chat about actually who you're speaking to in the home to make sure that you're getting the accurate information in terms of that symptoms, etc. And that is a question that I've been asked from advocates as well, and that's something we're looking at. But it would be about speaking to the registered manager, I think, because obviously they have a duty to tell us the accurate situation that they're in at the minute. So there is that, but it's questions. And I have to say, I'm not the advocate's choice at the moment, because when they come on and they look for a risk assessment, all I'm doing is asking questions. Well, how are you going to get in there? How are you going to get out there? In terms of, is there a garden? Is there this? Have you been on Google to look at the home? Have you been on Google to look at the house street view? All of that. So it really is down to the prep and questions. And it is time consuming, but it's all about safety. So yes, I suppose I am overcautious. Very much so.
Yeah, we would take a slightly different approach. If there was no evidence of COVID-19, it wouldn't be a blanket no. If there'd been no testing and things, we would try and obviously meet the person possibly outside. But we would try and meet the person.
Mm. And we do as well, just outside if we can. Yeah. If it's their home but they've got those symptoms, then no, it is more than likely that we wouldn't be going to that. But if just in terms of households, if people have got gardens and it's not breaking any confidentiality, and that's a possibility, it's about exploring all those possibilities with your clients and your patients and again the social workers, etc. So there is a lot in it, definitely.
Lovely. Well, thanks so much, Lindsay and Vicky, for
thank you for having us, Kate.
Thank you. Yes, thank you.
Pleasure. And so just reflecting some last minute comments that are coming in about we are learning together. We want to come together as a sector, don't we? And get it right. That doesn't mean not making mistakes. Of course, we're going to get things wrong, but so maybe we can do another one in a couple of weeks' time about what we've learned in the next 4 weeks, and maybe we can do that if you're up for it.
Brilliant. Thank you very much.
All right then. Well, take care, everyone. Go get them. Have a great weekend.
Thank you.
Thank you. Bye-bye.
Bye. Bye.